safe space.
Safe space.
Safe space.
Safe space.
Safe space.
A place where I can be free.
Somewhere I feel like I won't be judged.
My bedroom.
A place without fear.
Hi, and welcome to Safe Space, a podcast for open, honest, and deeply human conversations about mental well-being. I'm your host, Paulyne Wanyonyi, and I'm really glad you're here today. In this series, we'll be discussing suicide, a conversation that is much needed, not just in our country, Kenya, but around the world. Suicide is a topic that is often misunderstood and stigmatized. We have named this series Hushed Tones, Conversations on Suicide, to reflect how society tends to silence discussions about this issue. While we may mention it, it is usually done in hushed tones and behind closed doors. Even when we do talk about it, we often avoid naming it directly, as many of us are afraid. Due to this ignorance and fear, many of us hold various misconceptions. We struggle to engage in open discussions about it and understand it, and therefore, we often don't know how to address it. We would like to welcome you to accompany us as we confront what is often seen as the unspeakable, to examine and, if necessary, challenge some of our beliefs. This series aims to educate us all, and by the end, we hope that we can all be more empathetic, compassionate, courageous, less judgmental, and perhaps a little more curious. This series is not intended to provide solutions. Rather, it serves as a platform to amplify stories, share truths, and hopefully foster greater compassion among us all. Our focus will be on Kenya, as it is essential to amplify our voices. By actively listening to local and lived experiences, we can work towards addressing some of the mental health challenges present in our society. Throughout this series, we aim to create awareness, initiate conversations, debunk misinformation, and reduce the stigma surrounding this important topic. Consider this a place to start. Before we jump into why suicide happens or how we prevent it, we need to address something simple but powerful: words. The language we use. This is because how we talk about suicide shapes how we see it and how we treat people who are struggling. So let's begin with a basic definition. The American Psychological Association says, suicide is the act of intentionally taking one's own life. In Kiswahili, you might hear mtu amejiua. Both are technically correct, but still, you can feel the weight in those words. And that's the thing. Words carry a lot of weight. Sometimes it's not just what we say, but how we say it. For example, the phrase committed suicide sounds a lot like committed a crime. That kind of language adds shame and stigma. That's why many mental health advocates use phrases like died by suicide or took their own life. It's not just about politically correct, it's about being human. And you can see this play out in other areas too. Take HIV, for example. Back in the day, the way people talked about it created fear and judgment. Speaking about it in medical terms, it is a virus that weakens your immune system. But if you don't explain much else, that can leave space for myths and stigma. Over time, that's changed. Now we know that with treatment, people with HIV can live long, healthy lives. That context makes a big difference. And the same goes for suicide. When we look at the World Health Organization, they don't just define suicide, they call it what it is: a serious public health problem that needs a public health response. In other words, it's not just one person's issue, it's a community issue. Yes, things like depression or addiction can be involved, but sometimes it's just a moment of unbearable pain, a breakup, job loss, grief. These experiences can feel overwhelming, especially when you have little or no support available. And some groups are hit harder than others. For example, refugees or people in prison. And this is because this is also about inequality, trauma, and isolation. Closer to home, The African Institute of Mental and Brain Health, or AFRIMEB, based in Nairobi, puts it this way. Suicide is a complex and sensitive topic that involves psychological, social, and biological factors. Basically, it's never just one thing. Mental health plays a part, but so do your environment, your relationships, and everything happening around you. And then there's this powerful quote from psychiatrist Maurizio Pompili. Suicides always happen when a person's personal threshold for emotional pain is exceeded. That really puts things into perspective. It reminds us that it's not always about mental illness or a long medical history. It can be one deeply painful moment on a human level that feels like too much to bear. So, going off these ideas, suicide is complicated, but that doesn't mean we avoid it. It means we talk about it better, with more care and more nuance. Let's keep that in mind as we move through this conversation. Suicide is very much a lived or living reality for many people. So as we talk about this, we need context. We need to be open to listening, and we might need to reframe our own definitions. To kick off the interview episodes, this series we'll be speaking to clinical psychologist Dr. Tima Khamis. Let's get to the episode. So welcome to the show, Dr. Tima. Thank you for being here and for honoring our invite. To begin, could you kindly introduce yourself to our community?
Okay, thank you for having me. My name is Dr. Tima. I'm a clinical psychologist by profession, and I am based at Doctor's Park. My clinic is Adult and Developing Minds Therapy Services. I have been a psychologist for the last 24 years now. Yeah.
Okay. So thank you very, very much for being here. I'm honored that you accepted to do this with us. And this is the first interview episode of this series, and we'd like to use this episode to start the conversation about suicide. And to start us off, why did you feel it was important to say yes to this conversation about suicide, specifically in Kenya?
Yeah, I said yes to suicide because as a clinical psychologist, as a clinician, I get to see cases of suicide and self-harm on a weekly basis. And the cases are rising. Every now and then I can see how more and more people are presenting with symptoms that suggest that they have suicidal thoughts, suicidal ideation, and self-harm as well. So it is a big concern in our society today, and I feel like a space like this is important for us to address that issue. That is important, and it matters to our society, and in Kenya in particular.
And what would you say that suicide is something that is understood in our society? You say you see it a lot in your clinic, but do you think it's something that's understood generally?
I would say we are not quite there. It's partly understood and partly misunderstood as well. It's still work in progress. We still need to do more to raise awareness on suicide, to raise awareness on self-harm. And a lot of education is needed out there as well, so that people can really understand what suicide is, what it entails, what are the signs and symptoms, what are the things to look out for. And, because at the end of the day, there are quite a number of lives that are costed. When you look at the statistics, it's quite alarming. In Kenya, the statistic at the moment is that at least 4 people have suicidal thoughts on a daily basis. That is concerning. That is alarming. So it is high time that we address suicide at different levels for the purpose of enlightening their community, for the purpose of educating them, and for the purpose of saving lives as well, whenever we can. Yeah.
I think what's interesting about you is that you have said that you see you primarily deal with adults.
Yeah.
And I know you deal with a wide range of adults, still like maybe over 50 and all of that. And I think what is interesting is that many times when people hear suicide, they actually think it's something that's associated with maybe teenagers or much younger people. Could you speak to that in particular?
Yeah. So this is something that not only affects the young, but it affects people from different age groups as well. And I do get to see young people as well. That's why my clinic is called Adult and Developing Minds Therapy Services. So it's not just a concern for a particular age group, it's all over the spectrum. Yeah. So I get to see this in adults and I get to see this in young people as well. So it's presented differently in young people as opposed to the adults. Yeah. But it is a major concern in our country right now that needs to be addressed. So I'll give you an example. As far as young people are concerned, young people can either be brought to therapy by their parents because they have noticed certain signs that are not usual. You know, when it comes to self-harm, young people sometimes choose to cut themselves on their arms or the wrist. So the marks will be visible at some point, either at home or at school. And when it comes to the adults, they would come for therapy and they would not outwardly talk about suicide. They would present with either depression or anxiety, and then somewhere along the line is when they'll start talking about suicidal thoughts. Yeah, and then we'll have to address that as well. So both adults and young people present with suicide and self-harm differently.
Okay, that's an important point to note. When we say suicide, what are we actually talking about clinically, psychologically, and socially beyond the fear and taboo around the word?
Okay. So suicide is a reflection of intense psychological pain. And people who are suicidal do not necessarily want to kill themselves and die. It's a reflection of that. And it can also be a reflection of certain mental health conditions that are present. For example, depression, substance abuse disorders. There's a high association between substance use, alcohol and substance use, and suicidal thoughts. If you look at conditions such as post-traumatic stress disorder, same thing. It can also be presented with suicide or suicidal thoughts. Yeah, so those are the most common. And as I said earlier, when people come for therapy, they would come presenting with that kind of diagnosis. And then later on is when we will get to know that they also have suicidal thoughts. Yeah.
Okay, and there's this term that we often hear. We hear suicide, then we also hear suicidal ideation. So what is the difference between suicidal ideation and suicide, and how is suicidal ideation different from fleeting thoughts of hopelessness?
Okay, so suicidal thoughts are thoughts of suicide, but they're not recurrent, and they're thoughts that would come now and then, not concerning, not recurrent, and not serious as such. When we move to suicidal ideation, here we're talking about suicidal thoughts that are present and recurrently. They're thoughts that happen on a regular basis, and then they might also include suicidal planning. Someone might sit down and plan how they're going to commit suicide. And it might also include something like just, and it can be active or passive. So someone can repeatedly think of how they might die. Like someone could say, I wish I could just be driving and the car rolls and I die. And that thought is recurrent in their mind. And then to another person, it can be an active suicidal ideation whereby they're sitting down and writing down, planning how they're going to die. So if it is recurrent, if it's now disturbing them, then we move from suicidal thoughts to suicidal ideations. And that is when it becomes concerning.
Mm-hmm.
Yeah.
And just to take you back, you had just spoken about self-harm, and that's something that's often linked to suicide and suicidal ideation, which you've just spoken about. Can you tell us a little bit about the psychology behind this behavior?
Yeah, so self-harm is, from a clinical point of view, people go to self-harm so as to minimize the pain, reduce the distress, because the pain is too much, the distress is too much. And these are people who are not expressing their pain, they're not talking about their pain. So, of course, the alternative becomes, let me go to self-harm, because it will relieve, to them, it relieves that pain that they're experiencing. Yeah, and we also know that there's release of endorphins when people self-harm. So because it relieves the pain, people go back to it over and over again. It becomes like a coping strategy. But then, because of the benefits, then with time, it can be a behavior that they go to. And of course, that's not a permanent solution. It brings temporary relief. Yeah. And it can also be concerning when self-harm stops working. It does not really alleviate the pain, and then the person feels the need to go to alcohol, drugs, and other ways of coping. Yeah.
I just want to highlight something I've had you reiterate again and again, and I think it will help people understand. You keep saying that this is about release of pain, right? And that, I think that will help people understand that suicide is more complex than what people tend to believe or understand. And if we're able to view it from that perspective, I would hope that people would be able to have a bit more compassion and understanding for people who are going through something like that. You have mentioned a couple of times, we've spoken about a couple of times, and to that, I want to ask you, how important do you think it is to clearly name things and state them as they are instead of avoiding the term? So if we're talking about suicide, calling it suicide instead of calling it something else. Calling self-harm, suicidal ideation, and being clear about those definitions. Does clear language create safety? Does it help deal with the issue?
Yes, it does. That's a very good question. Yeah. Instead of avoiding, let's be honest and name what you're talking about. What is the problem currently? So if it's suicide, let's call it suicide. If it's self-harm, self-harm. And that goes beyond suicide and self-harm. What about the emotions that people experience to the point they get to attempting suicide or having suicidal thoughts? So we have to start from the basics. Yeah, the emotional literacy, the emotional language that some people lack. I have seen that a lot when people come for therapy, and I ask a question to do with what emotions have you been experiencing. There are some people who cannot mention those emotions because they don't have that literacy. Yeah, and so I'll have to help them identify which emotions they're experiencing. So I usually have a chart with different emotions, and I would help them identify the emotion. Yeah, so same for young people, emotional literacy is important, and it can start right from the word go. In schools, where kids are taught about emotions, so they start being in touch with their emotions, so that their parents can check in with them on a daily basis and ask, how are you feeling today? And someone can say, I'm feeling sad today, I'm feeling depressed today, I'm feeling frustrated and angry, and so on. So we have to start from there, so that by the time someone is suicidal, by the time someone wants to self-harm, they can articulate that without fear of shame, without fear of being judged, without fear of being looked at as inadequate, not strong enough, and so on. Yeah. So definitely naming suicide, self-harm, and other emotions is very, very important.
Okay. And you've mentioned, as you're talking, you've mentioned the community factor, which I think is also very important. the children, but also the adults in the situation. Because I can imagine a situation where if we're teaching children emotions and the adults are not able to receive that information, then it ends up being useless. But then if we deal with both ends of it, then we create a more wholesome system that I think would be helpful to everybody.
Yeah. So there's a lot of work that needs to be done in that area. Yeah. Which reminds me, I remember back then when I was doing psychology, and I think it was the first week of school, and it just got me thinking that we don't have names for certain emotions in Swahili.
Correct.
I remember thinking that. I remember saying, oh, we have all these emotions in English, but what about in Swahili? Yeah. Like sadness is huzuni, we know that. Happiness is furaha. What about frustration? Yeah? Yeah, angry is hasira. So that's the thing. We need to be in touch with the emotional vocabulary, both in English and Swahili as well. Yeah.
True. And just meeting people where they're at, because for some people, understanding these terms in English may not be something they can do.
Yes.
But that is an important point, which we will get to soon.
All right.
So in your experience, why does suicide remain one of the hardest mental health topics to discuss openly in Kenya?
Yeah, so it's because of the stigma that's attached to it, and because of the myths that are there around suicide. So, let's start from the faith point of view. We know that there are certain religions that shame suicide, that have labeled suicide as being a sign of, it's almost as if it's satanic. And when you commit suicide or think about suicide or even attempt suicide, it's a great sin and you'll go to hell. We know that. Yeah. And then just the overall stigma around it, being a sign of weakness, being a sign of, you're letting down the family, you're strong enough. Why would you talk about suicide? So cultural, religious interpretations have shaped our ways of thinking with regards to suicide. And because of that, there's a way people have kept quiet. People have not felt confident enough to talk about it. Yeah, because it's not a topic that is spoken about outwardly and openly in the society. Yeah. And then we know it was only last year, January, when suicide was decriminalized. Yes? Yeah. So there's an element of that. There's an aspect of that. Yeah.
And would you say there's a difference between the rural and urban setting in Kenya when it comes to this topic of suicide?
Yes, there is. Yeah. So in the urban areas, there's access to mental health facilities, and there are quite a number of differences between urban and rural. And from time to time, people would get maybe awareness on certain mental health conditions. They would get some, information on suicide and so on. But when you go to the rural area, the story there is different. Why? Because, first of all, let's start with accessibility to mental health facilities. How many mental health facilities are there in the rural areas that would address mental health concerns and suicide in particular? And then in the rural areas, I believe the myths, the stigma would be more pronounced there compared to the urban area. And that's why you'll hear interpretations of witchcraft in the rural areas, not really mental health related, but there's something about witchcraft and so on. So accessibility, the interpretations, the stigma, the attitude towards mental health all play a factor. And that's why there are those differences as well.
And I think I just want to emphasize on that point that, again, this is not an isolated issue. There are so many things we need to look at. And I think that also shows that we all have a role to play in the different sectors we're in. And if we involve one another, then we can help reduce the stigma around this topic and maybe get rid of some of the myths that are there and hopefully help people get the help that they need and deal with what I think is truly a crisis, a very silent crisis in our country. Now, going back to language, which we had just started speaking about, while researching suicide, it becomes clear that a lot of the information, whether it's the language and the statistics, they come from a Western perspective, and there's a lot of lack of local context, which can be a problem. So, for example, just like you said, there are many people in Kenya who might understand the issue better if it was spoken about in Kiswahili, even emotions, if we had some of these words in Kiswahili, maybe it would be easier to understand. Do you think what do you think about this gap? What does it do, when it comes to this topic of suicide? How is it affecting the way this topic is received and understood and dealt with in our country?
Yeah, that's a good question. So, yes, language is a factor as well. So most research, most of the information that we have out there is in English. Yeah. And here in Kenya, there are people who are conversant in English and there are those who are not conversant in English. So that can be a barrier, language factor, because not everyone, there are people who would want to understand more. What is the whole idea of suicide and mental health, the impact, how it affects people, what are the signs and symptoms, what to look out for, and so on. But because they are not very familiar with English, then they're going to be limited in terms of the information. So that can be a concern, and that's why I think some of the information out there, it would be helpful for it to be translated into Swahili. Yeah, and distributed in various setups as well, whether it's in hospitals, clinics, pharmacies, where people can read and understand in Swahili. Yes, that is a very, very important thing. I remember back then when I was doing my master's at University of Nairobi Medical School, there's a council called Population Council that contacted us to do a research on surveying the situation of young people in Kenya. And this was a survey that was taking place in the whole country. And because of language, we had to translate some instruments from English to Swahili. That was quality of life and Beck's depression inventory, so that we could go to the field and ask people questions in Swahili. Yeah. And I remember connecting with the people because there was a familiarity in language. We could speak in a language that they could understand. So yes, there is work that needs to be done in that area.
And going a step further from Kiswahili, even maybe also mother tongue, because for some
Yeah,
people
yeah,
that's even
yeah.
better understood.
Yeah. So we start from Swahili and then we branch to other languages as well. Yeah.
That must have been complex, translating things into Kiswahili, because there's the language aspect of it, and then there's the, how do you call it? Like the actual terms, getting the terms accurately. That must have been a bit of a complex.
Yeah. So I remember we had a workshop for a whole 2 weeks, just translating, making sure we're getting the words right. And we had people come here, to support us with that as well. Yeah. So language is an important factor to consider.
Yeah. Okay. And I like that you said that you are able to connect to the people, because when it comes to a topic like this that's often stigmatized, people are afraid of it, it's misunderstood. I think a good place to start is to break it down in a manner that people will be able to receive it well and feel, I guess, safe enough to receive it, as opposed to making everything intimidating, including the language. Because sometimes you start already with a language that is very intimidating. So by the time now we are getting to, actually talking about the topic, then it becomes a bit more challenging to actually deal with. Okay, so your work has circled psychoeducation and brings attention to mental health topics that are, for most people, difficult to talk about. Can you explain what happens psychologically when suicide becomes an unspeakable topic?
Unspeakable topic, eh? Yeah. So psychologically can you please repeat that question again?
What happens if psychologically when suicide becomes an unspeakable topic? How does, for example, secrecy affect somebody who's already struggling? or silence, how does that affect somebody who's already struggling? When this thing is unspeakable, what does that do to us psychologically?
Yeah. So, I mean, if you cannot speak about something openly, it means you're going to stay with it. It means it's going to be a secret, as you mentioned, and therefore there's going to be a build-up of emotions, that are not being expressed. And there's also going to be shame. I'm ashamed of talking about this because I'm going to be judged. I'm going to be criticized. So it does not help that someone does not feel safe to talk about how they're feeling and to actually say, you know what, I am having suicidal thoughts. You know what, I've been self-harming and I need help. So that safety has to be provided, whether it's at home, whether it's at school, so that people can come forward and express themselves without fear.
Mm-hmm.
Yeah, especially remembering that the stigma that is associated with suicide in the first place. Yeah.
And when we're speaking about the secrecy and the silence and how that affects people, what patterns have you seen in families and communities after a suicide occurs and that silence remains? We're not openly talking about it.
Yeah. So it's because of shame, being, judged. What will people say? So let me say something here. When a family member has suicidal thoughts or has attempted suicide, some families go back and blame themselves and say, we failed here. Yeah, this is a reflection of us as parents. This is a reflection of the society and so on and so forth. Whereas they forget that this person was suffering mentally. Yeah, they were mentally ill. And that's why eventually they attempted suicide. So it is so important to be able to separate those two, did this happen because this person just wanted to end their life, or he was unwell, he had an illness and ended up committing suicide? And because of that, what are we left with? What do we need to talk about? How do we need to process the grief? How do we need to address this issue moving forward? So that it's not about the family now, that, there's a lot of shame, there's a lot of stigma. What will people say? Yeah.
Okay, and that leads me to my next question. You've just alluded to that sometimes within families it can be very hard to talk about suicide when it occurs because they end up blaming themselves. How do we ask about suicidal thoughts without sounding accusatory or panicked?
Yeah. So the first thing that we need to do is to always ask with compassion. Compassion is the first step. And to allow the other person to feel safe with you. So instead of asking directly about suicide, maybe someone could ask something like, are you okay? I've noticed that of late you have been isolating more. I've noticed that you're not talking a lot like you used to. Yeah, I've noticed that your eating patterns have changed of late. I've noticed that you're more irritable than usual. Can we talk about how you're feeling? Yeah, you start from there. And then, of course, when the person now discloses and says, I've been struggling, I've been having suicidal thoughts, I'm tired, I feel like I cannot live anymore, then inquire more. Inquire more, ask more. Oh, I'm so sorry to hear that. That must have been difficult for you. Yeah, would you like to share more with me? It feels like you feel defeated, or it feels like you're giving up. What's going on? As opposed to, come on, that positive toxicity. Come on, what are you talking about? Just get on with it. People have it more difficult than you. You need to be strong because that's how you've been brought up, or maybe dismissing what has been saying and saying, that's a very small thing. You can get through that. Yeah. So really being compassionate with the person. Number 2, helping them feel safe. Number 3, giving them space to talk and meeting them where they are.
Yeah.
And then number 4, it's very important not to give advice. Let's start from a place of inquiry first. Get what this person is saying and understand what it is they need, rather than advise, rather than disregarding, rather than dismissing, or just, reminding them to move forward because this is not a big deal. Yeah.
And the examples you've given are actually very natural ways to talk to somebody, which I think eases that tension when you're bringing up this topic. And I think some people would say that, okay, but would asking then increase the risk of somebody actually committing suicide? What would you say to that?
It does not. It does not. Even the mention of the word suicide does not increase the risk. But there are ways of asking. By the time you're mentioning the word suicide, you need to start from a certain level. Yeah. So that's a myth that if you ask someone about suicide or if you talk about suicide, then the person will have more suicidal thoughts. That's not true. Yeah. Eventually, you will mention that word. But you have to start from a place where you need to create safety of this person sharing with you. Yeah. Because even after sharing, the person sharing is left with mixed emotions. There's a sense of relief that I have shared this, but there can also be a sense of fear. Yeah. A sense of confusion. Yeah. Or a sense of doubt. Why did I even talk about this? So it has to start from there and then eventually mention the word suicide or self-harm.
And when you're talking about creating that safety, what would that look like concretely? What would you tell people? Like, maybe do this or don't do that. That's how you can help someone feel safer when you're talking about this.
Yeah. So, number 1, sit down with the person alone. Confidentiality and privacy is important. Number 2, the language that you're using. Yeah? Minding your tone, body language, and all that. Number 3, the choice of words. So don't ask, what's wrong with you? Why are you looking so gloomy? What's wrong with you today? No, I'm noticing that you're gloomy today. I'm noticing that you're down today. What's up? Yeah, this is not your usual self. Something like that. Yeah. And then going with their own pace, not rushing them, because again, some people are not very patient listening to people with their concerns. Go with their own pace. Then the other one is to be comfortable with silence, to be comfortable with the tears, and then normalize the tears. It's okay to cry. It's okay to be vulnerable. It's okay to have all ranges of emotions right now. It's okay. Normalize it. Because as soon as you don't, then the person would feel like, okay, am I doing the wrong thing here? Am I feeling the wrong thing here? And they're not going to feel safe to share more. So normalizing is very, very important. And encouraging them to talk. Yeah. And also reminding them that you're there to listen and not judge them. And you're not going to criticize them. Yeah.
Okay, those are important pointers, very, very helpful pointers that I think people will benefit from, because I think there are many people who are at a loss when they're having such a conversation. Maybe they may approach it with good intention, but they don't know what to do. And in your experience, how do people usually respond when somebody opens up about suicidal thoughts? Now, we could wish that they respond in a positive and safe, compassionate way. But what tends to happen? Are we equipped to respond that way? Are most people equipped to respond that way?
I would say not all of us are equipped to respond positively, because of the topic itself, of the name suicide, So there are those who would automatically go to, oh, don't say that. Don't say that, that's wrong. That's a sin. Automatically that shuts down the conversation. Yeah? There are those who would just say, you should just think about your blessings, the things that you have in life. Be grateful for what you have, and yeah, you just go for a drink and you'll be okay. Or just go partying, or just, go talk to someone at the church or at the mosque and you're going to be fine. This is not a big deal. It's going to pass. So that's disregarding it's disregarding what this person is feeling. Yeah. So it's important to be able to just be okay with the conversations around suicide. Yeah. And not react with fear, apprehension, disgust, shame, judgment. Yeah. As if, come on, it's not a big deal. No. Because at the end of the day, when someone is talking about suicide, it's not as if it's attention-seeking behavior. Yeah? That I've heard that a lot. Oh, the person is just, an attention seeker. And that's why they keep on saying this. I've heard people say, let him go and commit suicide if he wants. Yeah, if he truly has the courage to do it, let him go and do it. I've heard people say that. Yeah, does he have, the courage to do that? And so on and so forth. So we need to take anything brought to us around suicide seriously. Make time for it, make space for it, and really bracket the myths, the faith-based, misconceptions that are there around suicide, and just be with the person, human to human. Yeah. Okay. It does not cost us anything just to be present and hear the other person out.
That's a really important message, and I hope people will be able to seriously take that. As you were speaking, I was just thinking to myself how there are many people who will go seek help in these spaces they typically occupy, whether it's the church, the mosque, you go to hospital or to school, and unfortunately most people are met with a lot of judgment and shame, just like you have said. And then now they have nowhere to go to. You're told those things you've said, like, if you truly want to do it, go do it. Like, what's wrong with you? How can you say something like that? That's wrong. And, it's a very unfortunate reception. And throughout this series, as we're having this conversation, I really hope more people will be open to having more compassion and understanding. And like you've said, meeting people at just a human level. And hopefully that can help to change things, hopefully. When we're talking about suicide with a younger person, there can be some dynamics that can complicate how open the young person feels they can be, especially if approached by an adult, whether it's a teacher, a parent. So if an adult suspects that a young person is struggling, how can they start that conversation?
Yeah, a very important question. So the first thing is to reduce the power dynamic. Because young people, you can imagine, just think of a young person and their world. Yeah? They're told what to do, what not to do. When they go to school, they have to, listen to the teachers. When they're at home, they have to listen to their parents. They feel like they're at the same level with their peers. So when we are approaching the issue of suicide with a young person, it's very, very important to minimize the power imbalance. All right? As soon as they feel like now you're there asking, interrogating, and they're going to be punished and so on, they're not going to open up fully. Yeah. I'll give you an example. When young people come for therapy, the first thing that I tell them is that I am not a teacher, I'm not your parent, I am not a family member, I'm a psychologist. And you are here because of a reason. I'm here to support you, I'm here to walk this journey with you, and I am not going to punish you, and this is not an interrogation. So I am going to meet you where you are. As soon as I say that, I usually see the young person calm down, and they feel more relaxed, and now they're ready to talk. So that's the first thing, to minimize the power imbalance. Secondly, it's the same thing, compassion, talking to them with a lot of compassion. Inquiry, asking them how they're feeling without necessarily fixing their problems, because sometimes they don't want to be fixed, they want to be heard. A number of young people have said this over and over again. I want to feel heard, I want to feel understood. Yeah, all right? No one understands me, so they want to feel that. Therefore, it is also important for them to be given a chance to talk and they need to be listened to. And then number 3 is when they're asked, so now that you have said all this, what do you need? What do you think would be of importance to you right now? Yeah? And of course, if the young person needs to be taken for therapy or to be taken to see the psychiatrist, that's when the parent comes in as well and proposes that and suggests that, while reminding the young person that they are going to support him to the full of their capabilities. Yeah. So listening is also important, meeting them where they are, understanding them, validating them, so that if the young person is not saying this and you're saying, but that's not a big deal. Avoiding comparisons, oh, but so and so went through this and look at where they are, that's wrong. Yeah. You can imagine all around them when they go to social media, all they can see is people doing this, that, and they can easily fall into comparison. So when a parent compares a child to another one, that is so wrong. It does affect their self-esteem. Then they feel like they're less than. Yeah. And this is just another thing that they have to tackle, that they have to, navigate through, and they don't know whether they will actually get there because they're not being heard and understood, and they're not getting the support they need. Yeah.
And you had previously mentioned that some people are told they're just seeking attention, and I would say especially younger people, especially teenagers, that's what they hear a lot. They're just being stubborn, or they're seeking attention, and they're not taken seriously.
Yeah. So they really want to feel heard, understood, validated. Yes, I hear you. This must be difficult for you. I didn't know you were struggling. Thanks for sharing with me. Thanks for bringing this to my attention. We are going to work through this together. We are going to navigate through this together. You are not alone. And then normalizing is so important. This is a common thing that young people go through. Again, because they usually feel like, I'm the only one feeling this way. Yeah? Others are having it, good, and they are carrying on with life. Why me? So normalizing is also important. It's a common thing that young people go through. And you know what? And giving them hope. You will get through this. Yeah? You're not going to be in this state forever. This too shall last. Take one day at a time. One day at a time, and you'll get there.
Okay. So, speaking about young people, I think this is a great point to bring in substance use and mental health. How does a culture of numbing through substances and distraction, sometimes social media, or emotional shutdown affect Kenyans today? I think primarily younger Kenyans today.
Yeah. And that is a worrying trend that I'm seeing right now. Yeah, very worrying indeed, because what is numbing? Why do people turn to numbing? It's a shutdown coping strategy. I don't want to feel, therefore I am going to distract myself. Yeah, I am going to scroll. As soon as I get a chance to scroll, I'm going to be on my phone scrolling. I don't want to feel the pain, therefore I am going to drink alcohol. I'm going to use substances. Yeah? For those who are into workaholism is a form of numbing as well. So eventually it becomes a coping strategy for them, but in essence, it's masking and not feeling certain emotions. And that's dangerous because eventually people reach a state where they would actually say, I am not feeling anything. Yes, I've asked people, how are you feeling today? And they say, I'm not feeling anything. Seriously, I don't know how to respond to that question because I don't know whether I'm feeling sad, happy, joyful. I'm not feeling anything. Yeah, and that is what we call a freeze response as well, yeah? Yeah, where someone is now numb, not feeling anything. It's dangerous. So if we can circle back to what we were talking about earlier, people need to be in touch with their emotions. They need to know which emotions they are experiencing. Put a name on the emotion. There's a psychiatrist called Dr. Dan Siegel who says you have to know the emotion for you to regulate it. If I don't know I'm sad, what am I going to regulate? Yeah, if I don't know that I'm experiencing high levels of anger right now, how am I going to manage my anger? I need to put a name to what I'm feeling first, and then go for a healthy coping strategy. Now that I'm feeling so sad, I need to know what the triggers are. What's made me feel so sad? Is it a memory? Is it a person? Is it a thing? Is it where I am? Do I go to certain places and all of a sudden I feel very sad? Yeah? And then come up with a coping strategy. When I'm sad, I can practice this affirmation. I can say to myself, this too shall pass. It's understandable why you're sad. Normalizing those emotions as well is important. Okay? Yeah. So naming the emotions, processing them in a healthy way is a very good way of preventing and reducing numbing in the young population. Yeah.
And when we speak about numbing and substance use, I think for many parents or adults, when they face that reality, they panic. They panic, and maybe they want to quickly judge the child or punish the child. What would you say is the best way to approach that? If somebody is having a substance use problem that could maybe be a sign that there's something bigger at play, how would you advise someone to approach that?
Conversations. Yeah. I mean, the parents need to get to the bottom of substance use. Yeah. Have those conversations, those difficult conversations. Yeah. And that just means sitting down with a young person and asking, what's going on? I've noticed that you've been smoking a lot of late. I've noticed that you have been drinking a lot of late. Is there something that we need to talk about? Yeah, because this is not healthy. It's not sustainable. It's going to cost you at the end of it all. Yeah, it has to start from those conversations. And I'm well aware that there are young people who do not like opening up to their parents. And the parent should be able to say, okay, if you're not comfortable sharing this with me, can I take you for therapy? Yeah, I can take you to a place where you'll speak to a mental health professional and they are going to help you out. I think parents need to give their kids options because there are certain conversations that young people are not comfortable to discuss with their parents. Yeah.
Okay, that's very important point. We've been speaking a lot about having these kinds of conversations, I would say in more private, intimate spaces, so within the family, within friend groups. What do you think it's important to talk about suicide publicly in media, in our religious spaces, in national policy? Or does that matter as much as having the private conversations?
So, yes, it's important to have these conversations in all those sectors that you've mentioned. Yeah, let's have the conversations in churches, in mosques, in different community events, yeah, different places. Because if we have these conversations privately, then what happens out there in the community? Private conversations sometimes will not get through the public. So it is important to approach this issue as a village. You know that saying that says, it takes a village to save a child. Yeah, it takes a village to rescue, and so on and so forth. So it will require a village to address the topic of suicide. Yeah, and we need to be on the same page so that we are not a village and maybe the faith spaces are talking about something different, mental health professionals are talking about something different. When you go to the government, they're talking about something different. Let's have conversations based on the facts, the reality, the situation that we're facing in right now. Yeah? And let's all work together towards really, really putting aside the myths, the stigma, and what people have been hearing over the years. Because by now we know those messages are not helpful. They're not helpful at all. Are those messages working for us? No, they're not working for us. They're working against us. Yeah? And the statistics, what we are seeing as mental health professionals, is evident of that. So let's do things differently, collectively.
Okay, collectively. Back to emphasis on the point of this is not an isolated issue. Everybody has a role to play, and we can all be involved in helping to deal with this issue. So to wrap up, is there one message you want to leave listeners with after this episode?
Yeah, so we should not wait for 10th of September, World Suicide Prevention Day, to address the issue of suicide. All right? Yes, we do acknowledge that day, and we should continue to acknowledge it. But in addition to that, addressing suicide should remain a daily thing, a weekly thing, a monthly thing. Yeah? So that continuously and consistently the messages are being sent around with regards to what suicide is, what are the signs and symptoms to look out for, what are the statistics, yeah? What does suicide cost to the families left behind, to the community at large? So it has to be an ongoing thing. We need to have ongoing conversations, and the stigma, we still need to work hard to work on the stigmas. And as I mentioned earlier, let's just do this collectively. It cannot be done by mental health professionals only. The others need to join in so that we're on the same page and we can deliver this message that can help save lives.
Okay, that is a wonderful point to stop at. Thank you so much for being here today. I'm sure our community will learn a lot from all the insightful points that you have shared with us. Thank you.
Thank you for having me.
Okay. Oh my gosh, how are you feeling now?
It's over.
It's over. What a wonderful conversation with Dr. Tima. To wrap up, I'd just like to emphasize one point that she made throughout the episode, that when we are speaking about suicide, when somebody approaches us to confide in us that they are having suicidal thoughts or suicidal ideation, we need to be able to meet them at a human level, to show them compassion, to create for them a safe space, and to be able to listen to them without judgment, without panicking, without shaming them or reprimanding them. And in that way, hopefully, we can start to make a difference within our personal lives and definitely in our society at large. That is all for this episode. Thank you for being here. Thank you for listening, and see you next time.